All right, so we're going to continue with the heart in looking at the conduction system. So for the heart, conduction is going to begin in the SA node or sinoatrial node that's in the right atrial wall. It's at the junction with the superior vena cava. So this has an unstable resting potential, and it will cause it to depolarize to threshold level spontaneously. So this spontaneous depolarization is what makes it have the potential to be the pacemaker. It propagates the action potential through the gap junctions in the atrial cells, and then the atria contract. So then it will reach the AV node eventually in the inner atrial septum. This is located just anterior to the coronary sinus. So here it enters the AV bundle or bundle of His. This is the only site where the action potentials are able to be conducted down from the atria into the ventricles. This is important because we want to have the atria contract individually first and then the ventricles afterwards. If all four are contracting at the same time, blood's going to squirt out in all four directions. That's not what we want. We want it to go from the atria to the ventricles and then the ventricles out into either the vessels to the lungs or the vessels to the body. So this fibrous skeleton is what electrically insulates it and allows this to happen. So once it goes through the bundle of His, it will enter into the right and left bundle branches that are going to extend through the interventricular septum towards the apex of the heart. And then it will finally go through the larger diameter Purkinje fibers and rapidly conduct the action potential to the remainder of the ventricular system, causing the ventricles to contract and pushing the blood up and out. So I like this picture here for illustrating this. So you can look at it and see where the impulse starts. So it starts at the SA node in the right atrium, and then moving down into the AV node, down through the bundle of His, and then into the right and left bundle branches, and around through the Purkinje fibers. So the SA node does act as the natural pacemaker. It has faster autorhythmic fibers than other places. Those autorhythmic fibers can initiate 100 times per second. And the nerve impulses from the autonomic nervous system and the hormones are going to modify the timing and the strength of each heartbeat. So that's going to be what controls it, is the autonomic nervous system. It does not establish a fundamental rhythm. So there's no true resting potential, but instead what it does is generates regular spontaneous action potentials. So the action potential that's initiated by the SA node is going to spread out and excite the working fibers, which are your contractile fibers. So with depolarization, you're going to have the contractile fibers have a stable resting membrane potential. They're going to be voltage-gated fast sodium channels that open and the sodium flows in and then deactivates the sodium flow in and decreases. So during the plateau, you're going to have maintained depolarization. This is partially due to the opening of the voltage-gated slow calcium channels that will move from the interstitial fluid into the cytosol. This ultimately is going to trigger contraction. Depolarization will be sustained due to the voltage-gated potassium channels balancing out the calcium inflow with the potassium outflow. The next stage is repolarization. Here you're going to have recovery of the resting membrane potential. So this is similar to what other excitable cells do. The additional voltage-gated potassium channels are going to open. You'll have outflow of potassium to restore the negative resting membrane potential, and the calcium channels close. So the refractory period, this is a time where you can't have a second contraction happen, and it actually lasts longer than the contraction itself. So the tetanus or maintained contraction cannot occur. That would cause blood flow to cease. So you need to have a little bit of time where the pump is relaxed in order to let the blood move. If it contracted again too quickly, it's not going to work as an efficient pump. So the contractile cells have an action potential that has an extended plateau phase. That's going to give it a longer refractory period to complete the contraction. So for skeletal muscle, the action potential lasts only 2 to 5 milliseconds. Cardiac action potentials last 200 to 400 milliseconds. So this picture here illustrates this nicely. The green is when you have depolarization occurring. So here in this upswing, you've got rapid depolarization from the sodium inflow. The sodium channels open. Here in this plateau, you're going to maintain the depolarization. You have calcium inflow and potassium outflow. And then you have repolarization here in the red. This is going to be due to the calcium channels closing and the potassium outflow. So the refractory period is highlighted in this yellow. Here is when it cannot contract again. And then the contraction phase is here. It's a little bit shorter than the refractory period. So this picture is going to take the same thing, but it's going to overlay the concentration of the sodium, potassium, and calcium ions in here. So you can see this sodium upswing is going to be what triggers everything to get going and is going to align with starting that action potential. So when we look at the pacemaker potential of the SA node, you can see that you've got this period here where you're going to depolarize up to the threshold and then trigger the action potential, and that it repeats itself over and over and over because of the autorhythmicity. See the electrocardiogram, this is going to look at the electrical activity of the heart, sometimes called the ECG or EKG. It's going to give you a written record of it. You can compare the tracings from different leads with one another and then compare it to normal. So we have 3 normal recognizable waves, the P wave, the QRS complex, and then the T wave. So the area in blue is going to be during atrial contraction. The area in yellow is what's going on during ventricular contraction. So you can see we've got the P, QRS, and the T wave, and then we have segments in between. So the PQ interval, we can have the QT interval or the ST segment. So during systole, that's the contracting phase, diastole is the relaxation phase. Your cardiac action potential is going to arise in the SA node. This is what's going to cause you to have the appearance of the P wave. And you have the atrial contraction or systole, and then the action potential is going to move to the AV bundle and spread out over the ventricles. This is going to trigger producing your QRX complex. So the QRX complex will be going on at the same time that the atria are starting to repolarize. It just masks that electrical activity. When we have contraction of the ventricles, this will start shortly after the QRS complex appears, and that's going to go throughout the ST segment. Then when we have the ventricular fibers repolarize, we'll start to see the T wave. And then following the T wave, we have ventricular relaxation or diastole. So your 3 waves that you want to know, the P wave for atrial depolarization, QRS complex for ventricular depolarization, and the T wave is ventricular repolarization. So we can graph it out, and we have time frames and then millivolts that we can look at on there. So this picture is nice because it's showing what's going on with the heart while this is happening. So here you've got depolarization of the contractile fibers. So you're starting the P wave. You can see up here, that means the atria are starting to contract. Then we go into the atrial systole, and we move here beyond the P wave, just beyond the P wave. So the P wave is when you have the electrical impulse to start the contraction, and then we have the contraction following it. Here's the QRS complex starting ventricular contraction, and then just following the QRS complex, the ventricles are contracting, and then they are repolarizing here with the T wave, and then we have diastole here where the ventricles are relaxing, and the cycle repeats itself. So arrhythmias are abnormal heart rhythms. Tachycardia is when the heart rate is too fast. It would be in excess of 100 beats per minute for a resting heart rate. It is normal to have your heart rate be above 100 beats per minute with activity. With bradycardia, the heart rate is less than 60 beats per minute. You do find times especially in athletes, where they may have a resting heart rate that is lower than 60 beats per minute, and it's not considered bradycardia. It's just a normal function of their heart being well adapted to the exercise. So when we see sinus arrhythmia, the heart rate varies about 5% during the respiratory cycle, and it can vary up to 30% during deep respiration. With premature atrial contractions, we'll see the occasional shortened intervals between one contraction and succeeding ones, and this can occur in healthy people. So here we can see a complete heart block where the P waves and QRS complexes are not coordinated. With premature ventricular contraction, there's no P waves that proceed in here. We go right into seeing a QRS complex. With bundle branch block, we can have prolonged QRS complexes. So you can see they're stretched out, they don't look normal. With atrial fibrillation, there's no clear P waves, and you can have rapid QRS complexes that will occur. And then with ventricular fibrillation, there is no P, QRS, or T waves at all. So this is showing what normal sinus rhythm looks like. You've got the P wave, and then the start of your QRS complex and a T wave. With nodal rhythm, you'll notice there's no P wave. The start of the QRS complex and the T wave following. And then with premature ventricular contraction, it's basically an extra systole here. You'll notice there's an inverted QRS complex that's misshaped, and the absence of a P wave preceding it. So there was no P wave preceding it here. You go into a T wave. And this is showing heart block where you've got an arrhythmia, and there was failure of conduction at the AV node. So you got the P wave going here because you had the SA node fire, but not the AV node. So the cardiac cycle is considered all of the events that occur in one heartbeat. So you're going to have both systole and diastole of the atria and ventricles. And in each cycle, you're going to have them alternately contract. So atria contract, then the ventricles contract. Atria contract, then the ventricles contract. So during atrial systole, ventricles relax. During ventricle systole, atria relax. This is going to force the blood to go from higher pressure to lower pressure. So it will go from the atria to the ventricles and then out to the body and the lungs. So during the relaxation period, both the atria and the ventricles are relaxed. So the faster the heart beats, the shorter the relaxation period. Systole and diastole lengths will also shorten slightly. So at 75 beats per minute, one cycle is going to require 0.8 seconds. So there are some volumes that we look at here. Your end diastolic volume is the volume that's left in the ventricle at the end of diastole. It's about 130 milliliters. The end systolic volume is the volume left in the ventricle at the end of systole. So it's about 60 milliliters. So the heart is not completely empty. So that means your stroke volume, which is the amount that gets ejected each beat, is about 70 milliliters. So when we look at the phases of the cardiac cycle, isovolumetric relaxation So iso means stays the same. This is the brief period when the volume in the ventricles doesn't change. So it's as they relax and the pressure drops and the AV valves open. So then we're going to have ventricular filling. This is rapid. Blood's going to go from the full atria into the ventricles. With diastasis, blood flows from the atria into the ventricles in smaller volume. When the atria go into systole or contract, that's going to push that final 20 to 25 milliliters of blood into the ventricle. So next stage would be ventricular systole. So we have isovolumetric contraction, a brief period again where the AV valves close before the semilunar valves open. So it keeps the volume. And then ventricular ejection, so the semilunar valves open and blood gets ejected. So this illustrates it here. Again, your systole with your periodic period of isovolumetric contraction. You go into systole with ejection. Diastole, where you have that brief isovolumetric relaxation. Then diastole, passive filling. Diastole, active ventricular filling. And it repeats. So this chart here is going to combine several of the things that we've looked at. It's going to show you the electrical activity here, so you can see where you've got the PQRS waves. This next section down here is going to look at the pressure. So in red, you've got the pressure in the aorta. Blue is the left ventricular pressure. And then down below, we've got the left atrial pressure. So you can see the left ventricle is going to have the higher pressure. So during the P wave here, you've got this little blip where you're going to have atrial pressure going down, or the aortic pressure going down, but you're starting to have a little bit of pressure occur in the left atria. Right after the QRS complex, that's when you're going to increase the left ventricular pressure. The left atrial pressure has a last little blip in there, and then it's going to drop back down. So then when it's repolarizing here, you're going to have the pressure in the left ventricle start to drop down. And then you've got this dicrotic notch here where you're going to have this little blip in the aortic pressure. And then you've got your left atrial pressure starting its little blip again to go into another P wave. So you can see here where the heart sounds are going to correspond with this as well. The S1 and the S2, which are the two that are easiest to hear. S3 and S4 are very subtle. This is going to look at the volume in the ventricle. So when the atria are contracting, it's going to increase the ventricular volume. When the ventricles are contracting, it's pushing the blood out. Here you can see this is the stroke volume, the amount of blood that's pushed out. And then it starts to fill up again. So this is going to show you the direction that blood is moving in these places here. So the blood moving into the ventricle when the atria contract, isovolumetric state. The blood getting pushed out during ventricular contraction, the isovolumetric relaxation, and then the ventricular filling and starting the cycle over again. So if you can sit down and spend some time looking at this table and really kind of walk yourself through it and have things make sense why the volumes are increasing and decreasing and the pressure is increasing and decreasing at a certain area, it's usually a pretty good indication you've got a good idea of how the heart is working. So this is just another one that isn't as well color coordinated of the same things happening. It doesn't have the picture of what's going on with the heart. So use the one you like. So auscultation is listening to the heart sounds. The sounds come primarily from the blood turbulence caused by the heart valves closing. So there are 4 sounds in the cardiac cycle, S1 and S2. Only 2 of them are loud enough to typically hear. Sometimes there are some people that can hear S3 and S4. That's typically somebody that is listening to a whole lot of hearts that's able to hear that. So S1 or lub corresponds to the AV valves closing. S2 or dub is going to correspond to the semilunar valves closing. S3 is the blood turbulence when the ventricles are filling. And S4 is turbulence during atrial systole. So we have the areas of auscultation here on the chest. So this is the patient's right side here, between the second and third rib, then over to the left side between the second and third rib, down at the level of the 5th rib, and then we move to the midclavicular line between the 5th and 6th rib there. So this picture is also going to coordinate where you're going to hear these different things. So where you hear it is not exactly over that spot on the heart. The areas of auscultation are where you hear the sounds best. So occasionally you may run into a patient that has situs inversus, where everything is backwards. They're on the opposite side of the body. But normally, the way we listen to the heart is the AV valve is at the right, second, and third intercostal space, just lateral to the sternum. Pulmonary valve is heard at the second and third intercostal space, lateral to the sternum. Tricuspid valve is at the 5th and 6th intercostal space, just lateral to the xiphoid process. And then the bicuspid valve is in the 5th and 6th intercostal space at the midclavicular line. So one way to remember this, there's a couple of mnemonics: anatomy and physiology, aortic and pulmonic. Pulmonary valves, tri and bi, tricuspid and bicuspid valves. The one that I learned was A, pet monkey, so A, P, T, M. So you use whatever helps you remember it. So looking at the cardiac output, that is how much blood is ejected from the left ventricle into the aorta. You can have a cardiac output on the right side as well. We just typically are looking at the left side. So the components that make this up are your stroke volume and heart rate. So we multiply those two together. In the typical resting male, you have about 5.25 liters per minute. So you have 70 beats per milliliters per minute, 75 beats per minute. You just multiply them together. So that entire blood volume is going to flow through the pulmonary and systemic circuits each minute. So your cardiac reserve, this is the difference between the maximum cardiac output and then the cardiac output at rest. Your average cardiac reserve is about 4 to 5 times the resting value. So when we look at regulating stroke volume, there are 3 factors that are going to help ensure that the right and left ventricles pump equal amounts of volume. So we've got the preload, contractility, and afterload. Preload looks at how much stretch there is on the heart before it contracts. The greater the preload, the more contraction. So the more you stretch it, the more it's going to contract. So this is the Frank-Starling law of the heart. There is more than one Starling's law, so this is Starling's law of the heart. That says the more the heart fills with blood during diastole, the greater the force of the contraction during systole. So the more you fill it up, the more it's got to push out. Preload is proportional to the end diastolic volume. So things that will affect the end diastolic volume: the duration of ventricular diastole. How long does it relax? And then the venous return, how much blood is brought back to the right ventricle. So when we look at contractility, there are a few things that will affect the strength of the contraction. So positive inotropic agents are things that are going to increase contractility. That would be epinephrine and norepinephrine, and then the drug digitalis. A lot of times they're going to promote calcium inflow during the cardiac action potential, and they increase the stroke volume. Negative inotropic agents decrease contractility. That would be anoxia, so a lack of oxygen, acidosis, some anesthetics, and increased potassium in the interstitial fluid. Afterload is going to be the pressure that has to be overcome before the semilunar valves can open. So if you have an increase in afterload, it will cause the stroke volume to decrease. The blood remains in the ventricle at the end of systole. So things that can increase this would be hypertension and atherosclerosis. With congestive heart failure, the heart doesn't pump blood as well as it should. So a lot of times this starts to back up. The fluid can back up in the lungs, causing shortness of breath. But it will also do that with the other side, meaning it's going to contract or start to back up in other parts of the body when it can't contract as well as it should, and you can have swelling and edema. So regulating the heart, we're looking at that cardiac output. It's going to depend on the heart rate and stroke volume. So adjusting the heart rate is an important way of controlling the cardiac output in the short term and blood pressure. Your autonomic nervous system and then the production of epinephrine and norepinephrine are going to be the most important here. So what's going to control this is your cardiovascular center that's located in the medulla oblongata. That's going to regulate the heart rate. Your limbic system, which is going to be involved with emotions, can influence the medulla oblongata. Cranial nerve 10, or the vagus nerve, is going to decrease the heart rate at the SA node and the AV node. So remember, the vagus nerve in there is going to be parasympathetic with your rest and digest. Vagal tone is your background firing rate. It's going to hold the heart rate to a sinus rhythm. It's going to give that background rhythm of 70 to 80 beats per minute. So if the vagus nerve is severed, the SA node is going to fire intrinsically at a rate of about 100 beats per minute. So again, bradycardia is when it's too slow, tachycardia when it's too fast. Normal is considered 60 to 90 beats per minute. So other things that will affect this, your proprioceptors in the muscles, tendons, and joints, they're going to send input to the medulla oblongata. So when you start to move, the medulla oblongata is going to get the information that you're going to move and increase the heart rate to deal with change in body position. We have chemoreceptors that monitor the chemical changes in the blood. Baroreceptors, they're in the major arteries and veins and the arch of the aorta and carotid arteries. These are going to monitor the pressure and give feedback. So one of the things, you can feel this area over your carotid artery, but one of the downsides of putting pressure on it is it can cause the blood pressure to drop. So in some cases, generally if you're working with a large group of people, they recommend you have them check their pulse on their wrist rather than on the carotid artery. It's not that you can't find it there, but because you could have them put pressure on there, there's a reflex that would cause a drop in the blood pressure, or sometimes they just get too aggressive and block it off altogether. Neither one are a good thing when you want to be keeping people safe and keep them upright. So the atrial reflex, or the Bainbridge reflex, is when the heart rate increases in response to a rise in atrial pressure. It's a compensatory mechanism, since the right atrial pressure is usually going to be the result of elevated left heart pressures from decreased cardiac output. So this is kind of a nice summary visual picture here, where you can see things that are going to influence the heart. So you've got your Cardioregulatory center here in the medulla oblongata. So sending messages and communicating with the baroreceptors, with the chemoreceptors. So you've got sensory fibers bringing information in. Your parasympathetic nerve fibers here going to the SA node. Sympathetic fibers here going to the heart. Sympathetic fibers going to the adrenal glands. So you can have epinephrine and norepinephrine be released. This is another picture that gives a summary of some of these changes happening here. So inputs to the cardiovascular center. It's going to take into consideration things from your higher brain, the cerebral cortex, your limbic system, your hypothalamus. It's also going to take into consideration things from your sensory receptors, your proprioceptors for movement, chemoreceptors for things going on in the blood chemistry, and the baroreceptors looking at your current blood pressure. Then it's going to send information back to the heart. So for sympathetic messages, it's going to send it through the cardiac accelerator nerve. So this can increase the rate of depolarization to the SA and AV nodes to increase the heart rate. It can cause the atria and ventricles to contract more, increasing the stroke volume. If it wants to slow things down, it can go through the vagus nerve, radial nerve 10, and that will decrease the rate of spontaneous depolarization in the SA node and AV node to decrease the heart rate. So that autonomic regulation, it's going to be in the cardiovascular center of the medulla oblongata. It's going to send a message out either through the sympathetic or parasympathetics. Norepinephrine, it's going to speed up the SA node and AV nodes, as well as enhancing the contractility. Parasympathetics, they'll release acetylcholine that decreases the heart rate and slows spontaneous depolarization. So this here looks at the baroreflex. So if you start with the cardiovascular center here, when you have an increase in the parasympathetic stimulation and decrease in sympathetics, you're going to decrease the heart rate and stroke volume. Then you're going to have the blood pressure decrease because you have a decreased cardiac output. So if it goes below or above, it can go the different directions. So if blood pressure increases because of the increase in cardiac output, in stroke rate volume, you can send that message in. If you need to increase it, you can have those baroreceptors detect that there's not enough pressure there and increase it. So it's all ways of having negative feedback loops in there. What I suggest doing is with these pictures, if you can sit down and just verbally explain this to yourself, it makes a big difference in being able to walk yourself through it. If you can explain it to somebody else, it generally means you have a good grasp of it. So chemical regulation. Hormones can affect this, epinephrine and norepinephrine to increase the heart rate and contractility. Thyroid hormones, they will increase the heart rate and contractility. When we look at your cations, an ionic imbalance can interfere with the heart's effectiveness. So you're looking at the relative concentrations of potassium, calcium, and sodium. So again, that's what this does here, looking at the chemoreceptors, where you have the normal pH range. So if your blood pH increases, you're going to head this direction. If it decreases, you're going to head this direction. Again, if you can sit down and kind of explain them to yourself, you've got a good idea of how the heart works. So other problems we can have with the heart, we've got ischemia, which is inadequate blood supply to the heart. Angina pectoris, this is chest pain. It's when the heart's not getting as much blood flow as it needs. Atherosclerosis, very common, fatty plaques deposited in the blood vessels. Arteriosclerosis is going to be thickening or hardening of the vessels. It's due to something else other than the fats in a lot of cases. An aneurysm is going to be a bulge in a blood vessel. This can be dangerous because it can result in internal bleeding. With myocardial infarctions, it's a lack of blood flow to the heart from blocking one or more vessels. So myocardial infarctions can be fatal. About 50% of them are fatal in this country. Risk factors for cardiovascular disease: smoking increases it, diabetes increases it, obesity increases it, being inactive, having high cholesterol, hypertension, and a family history. So again, this is a picture here that attempts to kind of summarize what is going on with the heart when you look if you increase contractility, decrease afterload, increase preload. Those are all things that are going to increase the cardiac output. Things that are going to increase the heart rate, so things going on with the nervous system, the chemicals, and other factors. And this is another flow chart that tries to coordinate those things all together as well. So things that are going to be affected by venous return, your atrial reflex, the autonomics, the hormones, are all going to affect heart rate. That affects cardiac output. These on this side are all things that are going to affect stroke volume. So the venous return, the filling time, preload hormones, contractility, the autonomics, afterload, and systolic volume, all are going to end up affecting the stroke volume. So that's going to look at blood pressure factors with the heart. Blood pressure is also going to have influences from the blood vessels, and we will look at those next time.